A heart attack rarely begins the day it happens. What shows up suddenly often started years earlier, quietly, without drawing attention to itself. Blood vessels don't usually fail all at once. They change slowly, they adapt, they compensate. And during that time, most people feel completely fine. That's where the misunderstanding begins. You can have cholesterol levels that look normal on a routine blood test and still be building the conditions that lead to a heart attack. Not because cholesterol doesn't matter, but because it doesn't tell the whole story. I'm Dr. Warren Hung, and if you care about protecting your heart over the long term, it's important to understand what is actually being measured and what is being missed. If you find these explanations helpful, consider subscribing. This channel is here to make complex health topics clear, practical, and easier to act on. Now, when most people check their heart risk, they're usually given a standard lipid panel. It includes numbers like total cholesterol, LDL, HDL, and triglycerides. These are useful. They've been studied for decades, and they do provide important information. But here's the problem. Those numbers describe cholesterol in a general way, not in a precise way. They don't fully capture how cholesterol is behaving inside your body, how it interacts with your blood vessels, or how much stress your vascular system is under. And this is where people get a false sense of reassurance. You might be told your LDL cholesterol is within range. So naturally, you assume your risk is low. But that number alone doesn't tell you how many particles are actually circulating in your blood. It doesn't tell you how likely those particles are to enter the vessel wall. And it doesn't tell you whether inflammation is already affecting the lining of your arteries. So the system looks stable, but underneath, something else may be developing. Inside your blood vessels, there is a thin inner lining called the endothelium. Think of it as a protective surface that helps regulate blood flow, prevents clotting in normal conditions, and keeps the vessel wall smooth. Over time, this lining can become stressed. That stress doesn't always come from one single cause. It can come from a combination of factors. Subtle inflammation, repeated exposure to certain lipoprotein particles, blood sugar fluctuations, metabolic strain, oxidative stress. None of these, on their own, necessarily cause immediate symptoms. But together, over years, they can begin to change how the vessel behaves. Small particles can start slipping beneath that inner lining. The body responds as if something is wrong. Immune cells arrive. A low-level inflammatory process begins. And gradually plaque starts to form. At this stage, nothing hurts. There's no warning signal. There's no obvious symptom telling you this is happening. And that's why it's so often missed. Many people assume that if something serious were developing, they would feel it. But cardiovascular disease doesn't usually work that way. It progresses quietly. It builds in the background. And by the time it becomes visible on a scan or causes symptoms, it has often been present for a long time. This is especially important as the body changes with age. As we get older, the ability of blood vessels to stay flexible and responsive can decrease. The repair systems are still working, but they're not as efficient as they used to be. The same level of metabolic stress that might have been tolerated earlier in life can now have a stronger impact. If someone also has conditions like insulin resistance, high blood pressure, or chronic inflammation, that background stress increases even more. So, the same normal cholesterol reading can mean something very different depending on the context. And this is where a key distinction matters. Cholesterol is not just a number. It's part of a system. What really drives risk is not just how much cholesterol is present, but how it is transported, how many particles are involved, how those particles interact with the vessel wall, and what the environment inside the body looks like. When those pieces are not measured directly, risk can be underestimated. Large population studies have shown this pattern repeatedly. For example, data from long-term cohort studies like the Framingham Heart Study and analyses referenced in guidelines from organizations such as the American Heart Association have demonstrated that a significant number of cardiovascular events occur in people who do not have extremely elevated cholesterol levels. That doesn't mean cholesterol is irrelevant. It means the measurement we rely on is incomplete. And this is where more advanced blood markers begin to matter. They allow us to see how many atherogenic particles are actually circulating, whether inflammation is actively affecting the vessels, whether metabolic processes are increasing vascular stress. In other words, they shift the focus from a static number to a dynamic process. Instead of asking, is cholesterol high or low, we begin asking, what is the body actually doing with it? And this change in perspective can alter how risk is understood. Because when you start measuring the right signals, you often see patterns that were not visible before. Someone may have acceptable LDL cholesterol, no obvious symptoms, and still show early signs of increased cardiovascular risk when these deeper markers are checked. That doesn't mean something is about to happen immediately. But it does mean the trajectory may not be as safe as it appears. And that gives you something valuable. Time. Time to understand what's happening. Time to adjust. Time to reduce the underlying stress before it turns into something more serious. This is the difference between reacting to disease and recognizing it early enough to change direction. And once you start looking at these more precise signals, the picture becomes clearer. Because not all blood tests are measuring the same thing. Some are looking at quantity. Others are looking at behavior. And a few are looking directly at the processes that actually lead to plaque formation and instability. Those are the ones that tend to predict risk more accurately. And once you see how those markers work, the limits of standard cholesterol testing become much easier to understand. When we move beyond basic cholesterol numbers, the goal is not to replace them, but to see the system more clearly. Instead of asking only how much cholesterol is present, we start asking how many particles are carrying it, how those particles behave, whether the vessel wall is already under stress. There are 3 blood tests that help answer those questions more directly. Each one looks at a different part of the process that leads to cardiovascular disease. And when you combine them, the picture becomes much more complete. Let's go through them one by one. 1. Apolipoprotein B, measuring the number of atherogenic particles. Apolipoprotein B, often called ApoB, is one of the most useful markers for understanding cardiovascular risk. To understand why it matters, we need to shift how we think about cholesterol. Cholesterol does not move freely in the blood. It is carried inside particles called lipoproteins. These include LDL, VLDL, and others. Each of these particles carries cholesterol. But here's the key point. Each atherogenic particle contains exactly one ApoB molecule. So when you measure ApoB, you are not just measuring cholesterol. You are counting the number of particles capable of entering the artery wall. This matters because risk is driven more by particle number than by the total amount of cholesterol inside them. You can have fewer particles carrying a large amount of cholesterol, or many particles carrying smaller amounts. Those 2 situations can produce the same LDL cholesterol number, but they do not carry the same risk. More particles mean more opportunities to cross into the vessel wall, more chances to trigger inflammation, more accumulation over time. This is why ApoB is often a stronger predictor of cardiovascular events than LDL cholesterol alone. Large cohort studies and analyses referenced in guidelines from the American Heart Association and the European Society of Cardiology have shown that ApoB correlates more consistently with cardiovascular risk, especially in people with metabolic conditions. This becomes particularly important in individuals with insulin resistance, type 2 diabetes, elevated triglycerides, central weight gain. In these cases, LDL cholesterol can appear normal, while ApoB reveals a higher number of circulating particles. So instead of asking how much cholesterol is there, ApoB answers how many delivery vehicles are in circulation. And that is often the more important question. 2. Lipoprotein A genetic risk that standard panels don't show. The second test looks at something that is not typically included in routine screening. Lipoprotein A, or Lpa, is a specific type of lipoprotein that carries cholesterol but also has an additional protein attached to it. This extra component changes how the particle behaves. It makes it more likely to promote inflammation, more likely to interfere with normal clot breakdown, more likely to contribute to plaque instability. In simple terms, Lpa is not just carrying cholesterol. It is also influencing how the blood vessel responds to injury and repair. What makes Lpa especially important is that it is largely genetically determined. That means lifestyle changes have limited impact on it. It can be elevated even in people who appear otherwise healthy. It often goes unnoticed unless specifically tested. Studies including large-scale genetic analyses and prospective cohorts such as those involving UK Biobank data have shown that elevated Lpa is associated with a higher risk of cardiovascular events, independent of traditional cholesterol levels. So someone can have normal LDL, good HDL, acceptable triglycerides, and still carry elevated Lpa, which increases long-term risk. This is one of the reasons some individuals experience heart attacks without clear warning signs from standard tests. because the risk was never fully visible. LPA doesn't replace cholesterol measurements. It adds another layer. It helps identify people who may need closer monitoring or a more tailored approach, even when everything else looks reasonable. 3. High sensitivity C-reactive protein detecting vascular inflammation. The third test looks at something different. Not cholesterol, not particles, but the state of the vessel itself. High sensitivity C-reactive protein, or hsCRP, is a marker of inflammation. More specifically, it reflects low-grade, ongoing inflammation in the body. And when it comes to cardiovascular disease, inflammation plays a central role. Plaque formation is not just a passive buildup of cholesterol. It is an active biological process involving immune cells, inflammatory signaling, tissue response. When the inner lining of the blood vessel becomes stressed, the body reacts. That reaction includes inflammation. hsCRP gives us a window into that process. It does not tell us exactly where the inflammation is coming from. But when elevated, it suggests that the vascular environment may be more reactive and more prone to plaque development or instability. One of the most well-known studies in this area is the Jupiter trial, which showed that individuals with elevated hsCRP, even with relatively normal LDL levels, benefited from interventions that reduced both cholesterol and inflammation. This highlights an important point. Risk is not only about how much cholesterol is present, it is also about how the body is responding to it. Two people with similar cholesterol levels can have very different levels of vascular inflammation, and that difference can influence outcomes. hsCRP helps bring that hidden layer into view. When you look at these three tests together, each one fills a gap. ApoB shows how many atherogenic particles are circulating. Lipoprotein A reveals a genetically driven risk that standard panels miss. hsCRP reflects the inflammatory environment affecting the blood vessels. Instead of relying on a single number, you begin to see a multidimensional picture. Quantity, particle behavior, vascular response. This does not mean everyone needs every test immediately, but it does mean that when risk assessment matters, especially in people with family history of heart disease, metabolic conditions, unclear cholesterol patterns, or unexpected cardiovascular events, these markers can provide clarity that standard testing alone may not offer. And once you understand what each one is measuring, the limitations of relying on cholesterol alone become much easier to see. But when these markers start to interact inside the body, the story becomes even more important because that's where risk begins to accelerate. Looking at each of these markers on its own is useful, but in real life, they rarely act in isolation. Inside the body, these processes overlap. They influence each other. And when they begin to move in the same direction, the overall risk can increase more quickly than any single number would suggest. To understand this, it helps to think of cardiovascular disease not as a single problem, but as a chain of events. It usually begins with particles in circulation. If ApoB is elevated, that means there are more atherogenic particles moving through the bloodstream. Each one carries cholesterol. Each one has the potential to interact with the vessel wall. On its own, that increases the probability of plaque formation. But probability is not the same as inevitability. The next layer is what happens when those particles encounter the blood vessel. If the inner lining, the endothelium, is healthy and stable, fewer particles will penetrate it. The system can manage the exposure more effectively. But if that lining is already under stress, the situation changes. This is where inflammation comes in. When hsCRP is elevated, it suggests that the environment inside the body is more reactive. The vessel wall becomes more permeable. It becomes easier for particles to slip beneath the surface. And once they do, the body treats them as a problem to solve. Immune cells move in. They try to clear the particles. But over time, this process can become inefficient. The immune response continues, but the material is not fully removed. Instead, it accumulates. That's how plaque begins to develop. Now, add a third layer. If lipoprotein A is elevated, the situation becomes more complex. LPA not only contributes to particle burden, but it also affects how the body handles clot formation and breakdown. It can promote a more pro-inflammatory and pro-thrombotic environment. So instead of a stable plaque forming slowly, there is a greater chance of instability. And that matters, because many cardiovascular events are not caused by gradual narrowing alone. They are triggered when a plaque becomes unstable, ruptures, and leads to clot formation. So when these three elements come together, increased particle number, ApoB, increased inflammation, HSCRP, increased genetic risk, and clot-related activity, LPA. You're no longer looking at a single risk factor. You're looking at a system under pressure from multiple directions. And this is where the idea of normal cholesterol can become misleading. Because cholesterol is only one part of the system. If ApoB is high, there may be more particles than expected. If HSCRP is elevated, the vessel wall may be more vulnerable. If LPA is high, plaque behavior may be less stable. So even if LDL cholesterol appears acceptable, the underlying conditions may still favor disease progression. This is especially relevant in people with metabolic conditions. When insulin resistance is present, the body often produces more triglyceride-rich lipoproteins. Over time, this can increase the number of smaller, denser LDL particles, many of which still carry ApoB. So the particle count goes up, even if the total cholesterol number doesn't change dramatically. At the same time, insulin resistance is associated with low-grade inflammation, so HSCRP may rise. Now the environment is changing on two levels. More particles, more inflammation. Add aging to the picture. As the body gets older, repair systems are still active, but less efficient. The endothelium becomes more sensitive to stress. Vascular flexibility decreases. Small disruptions are less easily corrected. So the same biological signals that might have been manageable earlier in life can now have a stronger impact. And this is why risk is not static. It evolves. A set of numbers that looked acceptable 10 years ago may carry a different meaning today. This is also why some people are surprised by cardiovascular events. From their perspective, they followed general advice. Their cholesterol didn't appear alarming. They felt well, but underneath, the combination of factors had already shifted. I remember a patient in his late 60s who came in after a routine checkup elsewhere. He told me his cholesterol had always been fine, and he had never been advised to look deeper. But he also mentioned long-standing fatigue after meals and gradual weight gain around the midsection, things he thought were just part of aging. When we looked more closely, his ApoB was elevated. His HSCRP was also above the optimal range. And his lipoprotein A was higher than expected. Individually, each result might not have seemed urgent. But together, they told a different story. And this illustrates something important about how the body works. The system doesn't fail because of one number. It shifts because multiple small changes begin to reinforce each other. That's when risk starts to accelerate. Not overnight, but steadily, and often without clear symptoms. This is why understanding the interaction between these markers matters, because it changes how you interpret the results. Instead of asking, "Is this number high or low?" you begin asking, "What pattern is forming? Are there more particles than expected? Is the vessel environment more reactive? Is there an additional inherited risk affecting stability?" Those questions move you closer to how clinicians think about long-term risk. They also make the next step clearer, because once you see the pattern, the focus shifts from identifying risk to managing it. And that's where these markers become practical, not just informative. They help guide decisions. They help prioritize changes. They help determine what matters most to address first. And once you understand how to interpret these patterns, the question becomes much simpler. What do you actually do with this information in everyday life? Once you see these markers together, the goal is not to chase numbers blindly. It's to understand what they're pointing to and how to respond in a way that actually changes the direction of risk. Because these tests are not just labels. They are signals. And each signal tells you something slightly different about what the body is doing. Let's start with a simple way to think about it. Instead of focusing on one number at a time, it helps to look for patterns. For example, if ApoB is elevated, that suggests there are more atherogenic particles in circulation than is ideal. The question then becomes, why? In many people, this links back to metabolic factors. Insulin resistance, elevated triglycerides, excess energy intake over time, reduced clearance of lipoproteins. So the response is not just lower cholesterol, but reduce the number of circulating particles. That often means improving how the body handles energy and blood sugar. In practical terms, that can involve improving meal timing and consistency, reducing highly processed carbohydrate intake, where relevant, increasing physical activity in a sustainable way, addressing weight distribution, especially central fat. The goal is not perfection. It's to reduce the pressure on the system. Now consider a different pattern. If hsCRP is elevated, that tells you something about the state of the environment, not just the particles. It suggests that inflammation is present, but inflammation does not come from one single source. It can be influenced by metabolic stress, poor sleep, chronic stress, underlying conditions such as periodontal disease, excess visceral fat, smoking, certain dietary patterns. So instead of treating hsCRP as an isolated number, it becomes a prompt to look for drivers. What in the body is creating that signal? And more importantly, what can be adjusted? In many cases, even modest changes can lower inflammatory burden over time, improving sleep quality, increasing regular movement, addressing metabolic health, ensuring adequate intake of whole, unprocessed foods. It's not about eliminating inflammation entirely. That's not realistic. It's about reducing unnecessary, persistent activation. Now let's look at lipoprotein A. This one is different. Because LPA is largely genetic, it's not something you can significantly lower through lifestyle alone in most cases. And that can feel frustrating at first. But the value of knowing your LPA level is not in directly changing it. It's in changing how you manage everything else. If LPA is elevated, it means your baseline risk may be higher. So the focus shifts to keeping ApoB as controlled as reasonably possible, minimizing inflammatory burden, being more attentive to long-term patterns. In other words, you don't ignore it. You use it to guide how carefully you manage the rest of the system. There are also emerging therapies being studied specifically to lower LPA, but at this stage, they are not yet widely used in general practice. So most of the benefit today comes from risk awareness and adjustment, not direct targeting. Now, when you combine all of this, a more practical framework starts to form. Instead of thinking, is my cholesterol good or bad? You begin thinking in 3 layers. Layer 1, particle load. How many atherogenic particles are circulating? Reflected by ApoB. Layer 2, vessel environment. Is the body in a more inflammatory or stable state? Reflected by hsCRP. Layer 3, inherited risk modifier. Is there an additional genetic factor influencing plaque behavior? Reflected by LPA. When you look at your results this way, interpretation becomes clearer. You're not just reacting to numbers. You're understanding a system. And that leads to more useful questions, especially when speaking with a healthcare professional. For example, is my ApoB consistent with my overall risk profile? Are there signs that inflammation is contributing to my risk? Given my LP, should we be more aggressive with other markers? What should we track over time to see if things are improving? These are the kinds of questions that move the conversation forward. Because cardiovascular risk is not decided by one test. It is shaped by patterns over time. And tracking trends is often more informative than looking at a single result. Now, one important point. None of this means that traditional cholesterol testing is useless. It still provides valuable information. But it works best when it is part of a broader assessment, not the only measure. When additional markers are included, decisions can become more tailored, more precise, more aligned with how the body actually behaves. And this is where the real advantage lies. Not in having more data, but in having the right data interpreted in the right context. So, if you've only ever looked at cholesterol in isolation, it may be worth discussing with your doctor whether a deeper assessment makes sense for your situation, especially if there is a family history of heart disease. Previous results have been unclear, or you want a more detailed understanding of your long-term risk. Because the earlier these patterns are recognized, the more room there is to adjust them, before they become harder to reverse. If this kind of explanation helps you make sense of your health more clearly, you can subscribe to keep learning in a steady, practical way. And if one of these markers stood out to you, or made you think differently about your own results, you can share that it helps guide what to explain next. At the end of the day, the goal is not to eliminate all risk. That's not realistic. The goal is to understand what matters most, early enough to act on it in a meaningful way. And when you start looking beyond cholesterol alone, that understanding becomes much clearer.